Well, that's it, everybody. Hello and welcome to the Institute of Health and Social Care Management and the latest in our digital technology special interest group meetings. We're thrilled to welcome some of our colleagues from the world of social care now. This is a combined group, and we've got a really good lineup of speakers for today to kick us along. Just while we're waiting for a couple of our speakers to actually come along, I've got a couple of pieces of news for the group that you may find interesting. First of all, after the absolutely exceptional commitment and expertise that June Hall had demonstrated for many months as our chair before she stepped down last month for the chair of the Digital Technology Special Interest Group, we're delighted to be able to announce that David Quo, one of our long-standing members, has agreed to come along and take that hot seat that June has vacated. So unfortunately, it doesn't look as if David can make it today, but we are looking forward to David taking over that chairmanship role in the future. So really looking forward to that. The other thing, I've got a date for some of your diaries, perhaps. So on the Tuesday, the 14th of March, the Canadian High Commission in London has invited the Institute to convene a Dragon's Den event for digital technology providers. There are 14 digital technology and life sciences companies coming over from Canada. The event will take place in the very, very smartly appointed Canadian High Commission on Trafalgar Square. And I'm after 4 volunteers to come along and take part as dragons in that event. That will involve interacting with each of the companies, giving them some advice and feedback. And then afterwards, we have a little bit of fun where we say, well, if we did have a great big stack of money, which of you would have got it? So if you would like to come along, it is a great experience. I've been to the High Commission before. It is absolutely magnificent. If you'd like to just drop Jade or I an email and we will send you details of that. So that's from 2 o'clock until 4:30 on Tuesday, the 14th of March at the Canadian High Commission in London, if anybody would like to come along. I should just finish off by saying that is a predominantly women's event because the 14 companies coming over are led by female digital technology entrepreneurs, and the event itself is in recognition and celebration even of International Women's Day. So if anybody would like to come along and take part in that, you would be really, really welcome indeed. The only downside is that, of course, I will be there. But there we are. Look, we are now, as I said to you, Rachel, that I'd be able to buy you a couple of minutes at the beginning. I've been true to my word there. I am absolutely delighted now to be able to welcome Teri Gavin-Jones and Rachael Grimaldi. I'll just introduce you properly. So Dr. Rachael Grimaldi is co-founder and chief executive of CardMedic, and you're going to hear a little bit more about what CardMedic is in a moment or two. And Teri Gavin-Jones is clinical lead midwife at Suffolk and North East Essex Integrated Care System. And Teri and Rachael are going to be talking about taking a purpose-driven approach to innovation to improve patient experience of maternity care. This is an absolutely fantastic topic. I think, Teri, you're going to begin, and then you're going to hand over to Rachael. This section will go on until about past, and then we've got another little nugget for you all to tuck into after Teri and Rachael have finished. So without further ado, I'm going to hand straight on to Teri. Thank you very much.
Thank you so much. Hello, everybody. Thank you for having us. It's really nice to be here. Now we have some slides. Do you want me to share the slides, Rachael?
Yeah, if you've got them available, otherwise I can do it, no worries.
If you've got them quicker than me, then
Yeah,
that would be good, actually.
share screen. I don't think I've got, I'll put share sound, but I don't think there are any. Let me just flip back to the beginning.
Perfect, thank you. Wonderful. Okay, I'll just move you on to the next slide. That would be great. So thank you for the introduction. My name's Teri Gavin-Jones, and I am a midwife, and I work across Suffolk and North East Essex. We have had quite a year really focusing on health inequalities in Suffolk and North East Essex around maternity services. We have endeavoured to create a 5-year equity plan, and our aim and vision is to really decrease the gap between those widening health inequalities. Next slide, please, Rachel. Thank you. So some of the figures that you may know, you may not, they're really stark. I think they're really stark. We know that Black women are 4 times more likely to die than white women in the perinatal period. If you're unsure of the perinatal period, that is pregnancy, childbirth, and postnatally. And we also know that Asian women are 2 times more likely to die than white women in the perinatal period. These are stats that come out of Embrace. Embrace is a national reporting system that tells us all of our figures around maternity. Next slide, please, Rachel. Again, another stark figure. I think it's really important that we focus our minds on these figures. If you are white and you live in the least deprived area, your chances of experiencing a stillbirth are 2.78 per 1,000 births. If you are Black and you live in a most deprived area, your chances of experiencing a stillbirth are 8.1. Again, so many health disparities around ethnicity. We know this. Next slide, please. This has focused our minds. We've understood that there are health discrepancies for our ethnic communities and minority communities, but it actually is a complex picture. Here in Suffolk and North East Essex last year, we decided to invest some money and we commissioned 7 voluntary organisations. What we understand in maternity is that we just don't have the capacity that we would like to bespoke the service towards our communities. We have to work with the third sector to create something that is more bespoke. Next slide, please, Rachel. So this is just a list of all of the voluntary and community sector organisations that we've commissioned. We worked with them last year. We're continuing to work with them again this year, and we've created some substantive funding to take them forward in partnership with us. Next slide, please. So what I can tell you about them is that when we asked our communities about what they wanted from maternity services in particular, they said they want information delivered by somebody who looks like them and sounds like them and who they trust. And for me, as a white midwife, it was really difficult to understand some of the cultural barriers, some of the, we often talk about seldom heard communities. And sometimes I think that's because we seldom listen. And here in our area, we've really tried to listen. So we've partnered with these organisations to say to them, what do you really want? What is it that's going to improve our care? Next slide, please. We've worked alongside the Core 20+5. I am a Core 20+5 ambassador. And you can see from this slide that maternity is one of our +5s. And there's a real focus on health inequalities alongside maternity here. Next slide, please, Rachel. So we are sharing what it means to work alongside VCSE partners is that actually as a midwife and as somebody who isn't embedded in these communities, I thought it'd be really easy. I'd go along, I'd share my wonderful maternity knowledge with them, and then they would then disseminate that out into the community. I was so wrong, if I'm honest, and it's been much more of a learning process for me than it has for them. So when I went out to the community, they said to me, stop trying to survey our women, stop trying to tell us what to do, sit and listen. What one of the community leaders told me is that actually you're not going to get anywhere without trust. You have to walk with our community, you have to eat with our community, you have to listen to them. So I have spent the last year doing just that, and I have learned an enormous amount. This is not a quick process, and we've really invested the time. The community in return has given us so much more. One organisation works with migrant women. 97% of the women they see are on their own. Those that are on their own have often left abusive partners. Most of them don't speak English, and most of them are not here legally. They are on their partners' visas or passports, and they are absolutely terrified, and they do not want to engage with maternity services. So this organisation has created what we call the Grandmothers Group. The grandmothers in these organisations have the innate wisdom. So I teach the grandmothers and we share knowledge, and the grandmothers then go and share that knowledge about maternity with the community, and it's working beautifully. Next slide, please, Rachel. So the saying, it takes a village, really is worthwhile in this community. As maternity services, we just haven't been able to reach these. And when I say we haven't been able to reach, that makes it sound like it's their fault, and it really isn't. We talk about lack of engagement. We talk about not engaging with services. It really is about us not bespoking the service to what this community needs. We have to be more flexible, and that's what that's taught me in the last year. When you start to reduce health inequalities in maternity, it's a bit like a jigsaw puzzle. There is not one thing that is going to fix this. There are many, many elements to this. One of those elements has been CardMedic. We see communication as a way in. If we cannot communicate with our population, then it leaves us really vulnerable, and it leaves them even more vulnerable. So CardMedic for us has been the way that we have introduced that communication. I'm going to hand over to Rachel.
Thank you so much, Teri. That's really inspiring to hear about, and we're absolutely delighted to be part of the solution. Like you said, there are so many elements to reducing health inequalities, but communication is such an important one. So I was just going to tell everyone a little bit about CardMedic, and just briefly to introduce myself. I'm Rachael Grimaldi, and I'm an anaesthetist, final year of training, and I'm working at Great Ormond Street Hospital in London, currently on maternity leave actually, and co-founded CardMedic at the start of the pandemic. So our mission really is to make communication and healthcare accessible. So whether you have a language barrier, whether you have a hearing impairment, some kind of cognitive impairment, learning disability, or you're not able to read, or visual impairment, whatever that communication barrier might be, we have designed CardMedic to overcome it. But actually, it was initially designed at the start of the pandemic. So I'll just take you through the story a little bit, and then I'll hand back to Teri at the end. But it started whilst I was on maternity leave previously and visiting family in the States when the borders closed and we were stuck there. And I'd really desperate to help, and I'd read about a patient who'd been to intensive care with COVID, and they were really terrified because they couldn't understand the staff. This was a chap, I saw him interviewed on the news, and he didn't seem to have any communication problems normally. I thought, well, if he's struggling, what's everybody else doing, and how are the staff communicating? Are they writing notes on paper? Are they shouting at patients? Are they just doing things to patients? And it was kind of a combination of everything, really. And so we thought, well, instead of people writing notes on paper, what about we just create a library, just an A to Z list of notes, pre-written scripts that a healthcare professional could access on a website, bring it up on a screen and show it to a patient, and the patient can read it. That was the initial idea. And it was concept to launch in 72 hours, very rapid. It was initially a website, then quickly also became an app. And we shared it with some friends. And 24 hours later, a good friend of mine said, you've got to join Twitter. And I had no idea how to tweet. But actually, in the first 3 weeks, just through word of mouth on Twitter, we ended up with 8,000 users in 50 countries. It had just spread. And then we had some media coverage, which went all over the world. And it was a mixture of kind of TV, radio, newspaper, and that sort of thing. But the feedback that we had from patients and from staff and members of the public and carers from all across the UK and internationally was, we need CardMedic to stay, because there are gaps in service provision and the scale of this problem is enormous. So just to give you an idea, altogether, those communication barriers I described, including patients who can't read, for example, make up nearly 50% of the population. And 69% of healthcare staff struggle to communicate with a patient daily or weekly, depends how often they're on shift. 89% feel current service provision is poor. 30% of medical litigation is directly due to poor communication. And this is estimated as an annual burden of £1 billion, looking at UK and US, because that's one of the biggest areas that we're working with. And the feedback was also about the gaps in service provision is not, we're not trying to replace translators at all. The gold standard would be to have an in-person translator for every person that speaks their dialect, that's culturally appropriate. It's, for example, in maternity, trying to ensure that it's a woman translating for another woman, for example, rather than a man translating for a woman. What we're trying to avoid is relying on friends and family to translate, or other staff members, or machine translation, which is what people often turn to because they have no other option. We don't want to replace interpreters, sign language interpreters, speech and language therapists, learning disability nurses. These are all the gold standards, but there is a big gap in service provision. And the feedback that we had was, please, can you continue CardMedic, essentially, which is where it ended up going from, a little project to help people into something much, much bigger. So we've already talked about the health inequities that are faced by patients with communication barriers. They have higher morbidity, mortality, mental health issues. They're less compliant with medication. They stay longer in hospital, and many more complications as a result of poor communication, including burdening the healthcare system even further. And there's no cost-effective kind of catch-all solutions, which is what we aim to be, is that there's that bridge for that gap in service provision as a safety net, as a tool in your back pocket, a digital solution just to help you communicate with your patient, whether that's an initial triage in an emergency situation. You might have someone, as Teri was talking about, you might have a refugee at 3 a.m. that comes in labor with baby's heart rate is dropping, and you need to quickly talk about going to theatre for an operation, or it might be in clinic, it might be in an ambulance, a GP practice, in the A&E department, anywhere where you need to communicate, or it might be more kind of routine, welcoming someone to a clinic or taking a history, for example. So we're just designed to bridge gaps. So this platform, as I mentioned, it's a website and an app. We have a library of scripts. We have nearly 1,000 scripts now. All are written by healthcare and allied healthcare professionals, which is amazing. So many people have reached out to us and said, I'd really love to add a script on whatever it might be. And we have a big maternity section, and we have all sorts: critical care, audiology, dermatology, ophthalmology. We have a pre-hospital air ambulance section. We're going to start building out primary care. The list goes on, but all are written by healthcare and allied healthcare professionals. Those scripts that you can bring up on the screen, you can then change to different languages, or if someone can't read, or for any other reason they want to listen, you can press play and they can listen to that being read aloud. We have easy read, and we're going to be adding in pictures for that. And we've worked the involvement of patients, public carers, and other national charities, other healthcare professionals has been essential to this. And we've had an amazing group of speech and language therapists and learning disability nurses who've been with us almost since the beginning, who are helping convert that content. And they've been such an incredible resource. So we have the sign language videos as well, as you can see an example there on the left, might be the right of your screen. So we've got the sign language videos, and then we have an inbuilt chat function as well. So it really is designed to be that flexible tool in your pocket. And just, this is a busy slide, but just to whiz through to say we're now in 19 trusts, including 5 ICSs, since we only commercialized just over a year ago. This is an expensive task to do, all the translating work and things, and ensuring that we have everything's culturally appropriate. So we need to make this a sustainable business, but the social impact side is really important to us. We've had 22,000 app downloads. That was from a little while ago. Since going out into the ICSs, we will have had a lot more. I'm part of the NHS Clinical Entrepreneur Programme. I had no idea how to do anything like this, so I've learned a huge amount of doing that and being on the Hill, which is another one from Oxford. Part of Digital Health Rewired last year. We've had funding from Innovate UK, which is from the UK government, and we've had angel and VC investment as well. But we've made sure that we align ourselves with people who care about making a positive social impact, because this is a global solution to a global problem. We've been on a number of accelerators, part of the Department of International Trade's Digital Health Top 100 Playbook. NICE reached out to us in the beginning, which was lovely, to endorse us against some of their guidelines. We've had lots of press coverage and lots of awards, and are also starting to work with hospitals in the US as well. But as I said, just at the heart of this is making a positive social impact globally. We've worked with refugees to do our translation, both in Kenya and with Ukrainian refugees who've come to the UK as well. We have supported humanitarian crises. Pediatric critical care retrieval team have used us to go out to Ukraine, and we want that to continue, and we want in time to come to be able to provide grants for female entrepreneurs in developing countries or healthcare entrepreneurs, and so on. So that's very much at the heart of what we're doing. So although it's a business, is very, very purpose driven, and we met Teri just through networking and on this kind of relatively small world of digital health, and we've had a huge amount of interest from maternity all over the country, and Teri has been an absolute force to be reckoned with when it comes to introducing CardMedic in maternity. So at that point I'll hand back over to Teri, and I'll keep flicking through the slides.
Thank you, Rachel. So, we are early adopters of Core 20+5, and we are early adopters of CardMedic as well. I think really importantly to us, it's not a tick box. We have to be seen to be doing something, but that doing something has to be meaningful. And it feels good to me to be able to say to our diverse communities, it's not perfect, but we're working towards it. I chair a maternity equity forum once a month, and I'm really proud to say that forum is not health-led, it's community-driven. I've got 55 community leaders who all turn up once a month, all of them, to tell me mostly what I'm doing wrong, which is great because it's a real learning forum for me. But they also tell me what's going right. And I came to it, as I said earlier, with a real clinician's lens. And what I've learned from them is actually we need to get more involved, and they need to trust. It's taken a long time, but the use of CardMedic he's building that trust with them. They can see that whatever we do, we are doing for the good, and we are trying. So there is more to do, because there's always more to do. Is there a next slide, Rachel? Yeah, questions. Does anybody have any questions? I think the last thing to say is that when we introduce CardMedic across the ICS, we are very maternity focused, and I do not have the capacity to onboard anybody else apart from maternity. But the interest in the other departments has been phenomenal, actually. A&E particularly have been interested. So we've had a lot of interest across the ICS, not just maternity focused. I think that's a real it's a great reflection on CardMedic itself.
Oh, thank you so much. I'll stop the screen share there. Stop share. But hopefully, if anyone wanted to drop us a note, they've got our details. But I don't know if anyone had any questions, or I might hand back to John for the chairing side of things.
I can see we've got a few hands already up. First of all, well done, you two. What a fantastic presentation. I thought that was insightful. It was summarized, it was compelling, and it was convincing. So many, many congratulations. Let's start off with June. You've got your hand up, June. What would you like to ask?
Okay, well, there's two questions really. Is there an audit trail within the app in terms of what you've shown people, and that it's, these are the conversations you had with people? Because I'm thinking, what differentiates this from Google Translate? For because you could just speak into something and translate it directly into their language, so I'm just struggling about what's the value add here.
Yeah, definitely. That's a great question. So it is very different than Google, but we do often get that question about Google Translate. So with the audit trail, yes, we can see with users what they've gone, if they've gone from one card to the next, and what kind of journey they've taken through. But in our roadmap, what we are planning on doing is having a tick box essentially on a card, where as a clinician you can say, I've used this card, this card, this card, and then that could be saved into the patient's health records. There's the actual amount of development work that goes into integrating with electronic health records is enormous. So it is a big part of our roadmap. We're not there yet, but part of that will be the ability to save the cards and the scripts that you've used. In terms of Google Translate, with CardMedic, all the scripts are completely pre-written by healthcare and allied healthcare professionals. They are all reading age of 8, or the Easy Reads reading age of 6. And because they are very simple, but accurate, they're they're professional but conversational, so friendly as well. And rather than Google, where you're typing or talking in line by line, which is obviously time consuming, the reading age, if you like, of Google is completely dependent upon the person who is talking into it. So they might be trying to explain something quite complicated. They might be using technical terminology. They might be using colloquialisms, and you just don't know how that's going to translate when you're going into Google. And of course, it is, as I mentioned, that time-consuming side of it. With CardMedic, we also have the easy read. We're adding in pictures. Google Translate doesn't have that. We have the sign language videos, which it doesn't have. And of course, it doesn't have a whole library. I mean, I can do a screen share of the website if there's time to show you the library of scripts, but it doesn't have all of those specialties listed on there with pre-written conversations by people who've been practicing clinically for a really long time. So and the other side is that we know we're not supposed to use Google Translate, but people do, because what's the other option? So where we are very different is that we're designed to overcome any communication barrier. So that might be language, but it could be deafness, or it could be a visual impairment, or it could be someone can't read and they want to listen to information. So I'm very happy, if you ever wanted to kind of jump on a call separately, I can do a demo and that sort of thing as well to run through it. But I hope that helps cover those questions.
Can I just add to that, Rachel, as well?
Yeah,
just because
quickly, if you will, Teri, we have not
Sure.
got a huge amount of time, and
Sure.
we've got David's question to come as well. Thank
Sure.
you.
When I'm using CardMedic, my front page has a profile with my picture on it, and it says, "Hello, my name's Teri, I'm a midwife," and it's really friendly, and it will translate that into various languages for me. And when you whip your phone out as a clinician in a room, everybody looks at you, they're wondering what you're doing. But I can hold the friendly page up, translate it into Urdu or whatever I'm using, and it will speak it for me immediately. And everybody just does that. They go, "Oh, okay, I know what you're doing now." Google Translate doesn't do that.
Thank you. Yeah, that's a really good point.
All right, let's hand on to, I hope that seems to be a fairly full response for you, June. Let's go to David now, who's got his hand up. The new chair of the Digital Technology Special Interest Group, David Quo.
Thanks, John. Amazing presentation, great idea. Thank you so much. I mean, my question is maybe a bit elaborate, and so therefore, maybe we should just agree to, communicate offline, Rachel, because my questions are around, what's your business model and what's your business plan? In other words, what's your commercial footing? How much does it cost? Are you charging for it? What kind of company are you? A for-profit or you're a non-for-profit? And also, what's your business plan? In other words, what are you looking to do next? What do you want from us here, for instance?
No, that's a great question.
You want to spread the word, or is there a specific project that you want to promote in your next stage? That sort of thing. So again, I don't want to pressurize some overall agenda for today, because I think that items to go on to. So maybe we could agree to explore those questions offline.
Yeah, definitely. Absolutely. I'll drop my email in the chat and I'll pick up with you. Just in very, very briefly, we are a software as a service solution, and we are purchased by hospitals or ICSs. And it's a very overall inexpensive, hopefully Teri agrees, solution. And it's for unlimited users on unlimited devices on an annual subscription, just to give you an idea. So you can use it on computer or iPad, mobile phone. It's primarily used by staff, but patients could also download it too if they wanted. But yes, absolutely loads to talk about. So I'd love to pick up with you over email and then have a meeting to chat all of that through as well. And I can bring some other members of the team along.
Super. Thank you very much.
Thank you.
There you go, folks. Weren't they good? Goodness me. I mean, we do a lot of these things. We do a lot of presentations. We've seen a lot of presentations, not just in this group, but, anybody that's been remotely connected with kind of communications through COVID. We've all seen thousands of online presentations. I commend you too. That was right out the top drawer. Thank you very much.
Thank you so much. Thank you for having us.